Hello and welcome to the first session of our online A to Z in dental implant therapy. There'll be 6 sessions. In each of those sessions we'll try to cover the things most pertinent to implant dentistry as we see it today in 2007. Probably the biggest change in implant dentistry over the last few years has been the realization that we need to respect the biology to the point of giving us predictability of how the final restoration will turn out based on where the implant will be placed. So for us, it's very exciting to have that predictability, and we'd like to share that with you. This session will be involved in first understanding that biologic predictability, and then what are the restorative issues. So this is probably the most important core of all the sessions to follow. So I think when we look at implants and practice success, probably the most exciting thing in my office has been the realization of really how straightforward and reasonable implant restorations can be. And there are certain keys, though, to create the success that we all want to have. I think the bottom line is that we create or develop an environment where all tissues, including soft tissues, are stable. I don't believe that we can include a success an implant situation where the soft tissues are continually changing, or you'll read about creeping attachments. We find that unreasonable, and we should have stability, and in fact, on the great majority of our cases, that's what we see. In order to have that predictability, we need bone, and the bone needs to be present to allow the development of the soft tissue with that stability that we find so important. The correctly sized implant needs to be in a specific biologically compatible position to produce the aesthetically and functionally stable results that we desire to have the success that we're looking for. But ultimately, especially from the restorative point of view, success depends on the patient's acceptance of the final result. This is achieved through patient education and communication skills. So part of these sessions certainly is evaluating and examining how we can talk to patients, how we develop a relationship with them that keeps them on our sides and makes them understand the advantages of implant dentistry as well as the challenges and the limitations of any dental restoration. Another way to look at the biologic basis of our philosophy is that restorative success is dependent on the implant being in the right position. This position is determined by basic biologic parameters. If healthy bone exists or is created in the right position, and the implant is placed according to these biologic principles, the correct aesthetic display of the soft tissue will follow. For me as a restorative dentist, I need in my general practice the confidence that I can restore it to the level that the patient requires for their appreciation and acceptance of that result. We need to be able to predict to the patient what the final result will look like. It isn't just stick the implant into the bone and hope that we can achieve whatever result it might be. We should be able to look at the case, have a consultation with our surgeon to understand what the surgical complexities might be so that we can speak intelligently to the patient about a range of possibilities that they may encounter in the final result. Our skill as restorative dentists come into play in that we can take sometimes less than ideal implant placement and still make it look acceptable to the patient. So that's our skills, but we really prefer, and if we can begin with a case with the implant placed ideally, then we get a much better and more predictable result. To achieve all these things, certainly I'm a strong believer in having talented people working with me. I, as a restorative dentist, understand the challenges that I face, and I understand that if I have a very good surgeon and a very good laboratory technician, I can achieve at the highest possible level. Part of my job certainly is communicating with the patient what these results might be and the limitations of them. My great appreciation is when the surgeon also sits down with the patient and talks about the restorative challenges and not just glosses them over. Don't worry, the restorative dentist will take care of that. I need a team effect really with the surgeon so that we can both examine the challenges that are ahead of us and then create a good working environment with the patient as well as everyone else. From the office staff point of view, they need to reinforce and support the things that we say to the patient. Quite often I might say a lot of things to the patient and I feel that they understand it well, but then as I leave the room I notice that they're asking the office staff the questions that I thought were handled very clearly while I was there. So it's very important for everybody to be on the same page. And certainly for all of us, for the restorative dentist to understand the limitations surgically, and for the surgeon to understand the limitations restoratively. I sat down and I thought about what the potential issues might be in terms of restoration. I've said already that I love ideal implant placement. I haven't really defined that yet, but we will. With ideal implant placement, it's almost anything that I do will give me the correct emergence profile, the correct interdental papilla, and then with a reasonable laboratory effort, we can have a nice aesthetic restoration. But what do we do when we have non-ideal implant placement? Whether intentional or lack of actual planning, but we end up with a situation that isn't ideal. And then also compounded with the fact that we've lost our soft tissue contours. How do we handle that? It isn't guaranteed that we won't get an ideal result. It's possible that through careful manipulation of the soft tissue, we might be able to create still a wonderful emergence profile, a nice aesthetic frame to the restoration with the soft tissue. But there are limitations, and sometimes the limitation might be a lack of soft tissue and or bone, and the restoration that we must develop will be require some prosthodontic management of that soft tissue defect. It also might require a different contour to the interdental porcelain. It might require the use of pink porcelain, restoration of adjacent teeth, and even the use of removable overlays to achieve the aesthetic result that the patient wants to have. Another thing we need to look at, which remains still a somewhat controversial topic, is immediate placement and provisionalization. The reason it may be controversial is that there's a range of techniques that are seen, and some techniques are not as conducive to immediate restoration as others. But when we can successfully place an implant immediately with the extraction of the tooth, without the loss of the soft tissue contours, if we can maintain that, to me that can be one of the most conservative ways of managing a case possible. But of course it's not acceptable to look at a lower success rate just because we're placing immediately. In fact, we should strive for a higher success rate because of the situations that we're in. All right, now when we think of ideal implant placement, we realize that placing the implant in the right position allows the restorative dentistry to occur more easily. But for the restorative dentist, it's also how we manage the case. This is a young man that had an encounter with a baseball, instead of in his glove, in his mouth, which fractured off tooth number 7, leaving only a fragment above the tissue, broke the corner of tooth number 8, avulsed 26, and broke the corner of 25. So of course, on an experience like that, late in the day, an emergency patient that shows up in your office, there's many questions that go through your head. Do I need to extract number 7? It's no longer salvageable. My concept would be to leave the root if you're not prepared to place an implant immediately, to allow you to have the time to talk to the surgeon, to work out the logistics of the restoration, and also to communicate to the patient what we can accomplish. In this example, basically we just numbed up the patient, ground the fragmented part of tooth number 7 below the tissue, bonded on the tooth number 7 in place, and honestly, 7 days later he looked good. The root was still subgingivally sitting there waiting for our restoration. 6 months later, Dr. Jovanovic and I went into the case. Dr. Jovanovic removed the root and, looking at the socket, placed an implant. And the key here is the position of the head of the implant. So many times we think it doesn't really matter, or to be safe, let's sink the implant further. It's an immediate extraction site. We've laid a flap. We know we're going to lose some of that labial bone. But still, we know, and really the things that have been shown to us over the years, is that if the head of the implant is placed in a very narrow parameter of 2, 2.5, maybe 3 millimeters from the desired emergence profile, we will predictably achieve the emergence that we desire on every case. So that common sense thought of sinking the implant further for greater success is absolutely totally wrong. The further the implant head is seated, it may give you comfort right when the implant placement is occurring, but will not give you the restorative success we're looking for. So here we see an example of the head of the implant placed, and you see this large space around the implant, and you think, well, that's not good, we need a larger implant. The next thing I really want to think about is the biologic predictability of the bone surrounding the implant. The only thing a larger implant does on this case is reduce the biologic potential. The less bone that we have in that area, the less soft tissue support, the less support to the implant itself. So we really don't want a larger implant. We also notice how carefully Dr. Jovanovic placed the implant to the adjacent teeth. If the implant gets closer than 1.5, maybe as small as 1 millimeter, but certainly 1.5 to 2 would be ideal. As the implant gets closer, we're reducing the biologic potential of that bone and perhaps leading to bone loss from ischemia, lack of circulation, or actual bone loss from the implant placement. So a larger implant isn't an advantage on this case. But of course, the surgical skill comes in how to manage that defect, the grafting techniques that are involved, probably a 2-stage procedure with this magnitude of a graft, followed by an attachment of a healing abutment, and then whatever restoration we decide to create, whether it's a ceramic CAD-CAM type abutment and a cemented crown, a screw retained crown. There's literally hundreds of ways that we could restore this case, but the key here is that because the implant was placed ideally and because we managed the case well, we're able to go ahead and get this wonderful result with very simple effort on the restorative side. We look at that case and then we turn our attention to a case like this one, which I'm sure to everyone that's done implants is the most disappointing result that we can possibly achieve. We have a relatively young patient, a nice aesthetic smile, and then one tooth. The implant retained a lateral incisor is literally 3 or 4, 5 millimeters longer than it would be ideally. We have a lack of soft tissue, and then we look and we see this very red and shiny area above the implant, and that immediately implies that there's no bone there. When we don't have bone, we realize that we're not going to have a stable situation, and there is no surgical skill that would allow us to graft soft tissue into that area. When there's no bone, we can't create the soft tissue. How do we manage a case like this? Another way to look at this case is you realize when you look closer, if we showed you the x-rays, that the canine is actually a retained deciduous canine. One thing that often leads to restorative and surgical failure is a failure to treatment plan the whole patient. We need to look at the whole patient and make a decision. Should we remove that deciduous canine? And in this case, I think that was a definite. We do have that opportunity now, though, that we could remove it. When we look at the surgical retreatment, though, we realize what a challenge these cases are to retreat. And here we see a 5 millimeter diameter implant that had been placed, no bone labially, and probably even worse is that the implant was placed so close to the natural central incisor, trying to maintain that bone can be extremely difficult and lead to future problems. So removing that implant, grafting the site, perhaps extracting the retained deciduous canine, placing an implant in that site, and we might consider, and we have, cantilevering the lateral incisor off that implant on the canine site, just because reconstructing this site now that is so damaged by a malpositioned implant, it's very difficult to proceed with the case. When we can place the implant ideally, the key here from a restorative point of view is that I can be predictable with my patients. I can talk to them during treatment planning about the result that we can achieve. We can educate the patient perhaps to doing crown lengthening on adjacent teeth, restoring adjacent teeth, whatever might be required to achieve the result that we want to have. What are these numbers? Now, I'm not going to go into them in depth. I know that Dr. Jovanovic in his surgical series will cover these things, but I think it's important for the restorative dentist to understand these numbers, even from the point of view of talking to the orthodontist. I've had so many patients referred to me ready for implant restoration, and then I get the case from the orthodontist, and basically there's 5 millimeters of mesiodistal space for the restoration, and we all realize that except in very limited situations, that's impossible to do an implant restoration with any kind of predictability. So the numbers as I see them that are critical is that the ideal distance to the adjacent tooth is 1.5 to 2 millimeters. Now I realize that we can look at many cases and see, oh look, there's only a 1 millimeter space here. But if we begin these implant placements with such a tight tolerance, and the drill drifts maybe just a 0.5 millimeter, and all of a sudden we only have a 0.5 millimeter of space, and we end up with a surgical restorative failure, and the patient is not happy. The next important number that I think we should all understand is where the head of the implant needs to be to achieve the emergence profile we'd like to have. We can't place the implant 7 millimeters apical to the desired emergence profile and then achieve the predictability that we want to have. We can't achieve that emergence profile. So we need to have the surgeon understand that the head of the implant needs to be within a certain range so that we can achieve the result we want to have. For especially the anterior placement of implants, the labial plate tends to be thin and very easily damaged. If we place the implant too far labially, we can press on that labial plate, leading to bone loss, and as we saw in the previous case, the lack of bone, the lack of soft tissue, and a terrible restorative outcome. So we like to see at least a 2 millimeter lingual positioning of the labial edge of the implant from the desired emergence profile. For the restorative dentist, during a restorative planning session, we also need to understand how much space needs to exist between implants. We've mentioned that we need 1.5 to 2 millimeters between a natural tooth and the implant. We need more space between two implants because of the reduced biologic potential in that area. We don't have the same connective tissue fibers, we don't have the same support fibers that are embedded in teeth to help support the bone in those areas. So we need more space. We would like to see 3 to 4 millimeters of space between implants. Quite often we realize when we look at, let's say, an anterior edentulous area between teeth number 7 and 10, if we don't have a significant amount of space, the concept of placing one implant per tooth just doesn't work. We need really to think about a bridge, maybe 2 implants, to restore that 4-unit space. As a restorative dentist, along with all these other factors, I need to think about how I'm going to do the restoration. I need a certain amount of occlusal clearance for whatever abutment that I'm choosing to use, and I need to communicate that to the surgeon. In today's world, the use of cemented crowns is becoming more and more popular, but we still need to understand that we need a certain height to the abutment that will allow cementing of the restoration. We need a certain axial wall. We would like to see the cement line near or close to the gingival margin. If we're forced into cementing a crown 3 or 4 millimeters subgingival to achieve enough retention, that is not going to be a long-term biologic success with a cement line that is so far subgingival when we realize that there's no way that we can completely remove all of the cement. We can also think as a restorative dentist the type of implant system that we want to use. Would we like an external connection, an internal connection? We still use both types of implants to great success, depending on the situation. We realize that there's certain biologic value to using titanium, but the biggest occurrence over the last few years has been the realization that the surface texture of the implant certainly leads to a change in how rapidly bone can be developed on the surface of the implant and even the strength of the bone that is developed. We look as restorative dentists at the different diameters of implants, realizing that the biggest issue here is the strength of the implant itself. My concern as a restorative dentist is that the implant never be chosen based on the amount of available bone, but based on the force that will be applied to the area. Where it might be very reasonable to use a narrow platform implant in the anterior segment where the loads are lower, I would never want to use a narrow platform implant in a posterior quadrant where I know that the loads might be extremely high. The heads of the implant, as I mentioned, really is sometimes a personal choice, but there are certainly advantages to some of these new implants and the implants that we've been using for many years, and we look at each one independently. As a restorative dentist, I need to understand certain restoration design options. Over the next 5 sessions after this one, we're going to consider the design options for anterior teeth, for posterior teeth, for edentulous situations. And we need to understand those particularly, but in general, we need to realize that we could do individual crowns in many cases, and we also see situations where a splinted final restoration may be to the patient's advantage. That could be a bridge, 2 implants to replace 3 or 4 teeth, in the anterior segment certainly, but it also might be a bridge on 3 implants, a 3-unit bridge. Why would we do that? We need to talk about those issues. Although it's becoming quite popular, and I think the most standard thing is to cement the final restoration. I can tell you that there's many times that the only way to successfully restore a restoration is with a screw retain design, and sometimes it's easier. It's sometimes more predictable to do a screw retained. And I'm only saying that because I think it's important for us to master all aspects of implant dentistry so that we can decide on any given case what's the best way to restore the case for that individual patient. There's certain standards in terms of occlusal design and materials that we need to look at, but basically there's a lot of options and a lot of ways that we can restore any given case. When I do restorative lectures, probably the most difficult thing for the person listening to the lecture is to grasp all the abutment options. My goal today and during most of the lecturing is not to try to teach you every abutment option, but it is to try to give you the skills so that you can understand the different abutments, so that regardless of the name or the newest ones that come out, you can look at it and understand that it's perhaps a custom abutment, it's perhaps a custom abutment that will be cemented in place or screw retained, what's the flexibility, what's the interocclusal clearance, and then you can understand how you can best utilize it. This chart helps me understand and look at cases for when I want to splint the final restoration or when I want to do individual crowns. Of course, we all think of the ease of creation. And so many times it's sold as, well, it's easier to do individual crowns because we can cement the individual crowns and it's just like regular dentistry. But in some cases it's much harder, especially on some aesthetic cases, which might surprise you. To do splinted crowns, the number one thing is we need an outstanding lab support. And also from the restorative point of view, you need to know and have mastered the techniques to taking an accurate impression. If you haven't mastered those techniques, we'll have significant issues. Individual crowns, on the other hand, can make up for maybe marginal lab support. You might have heavy contacts that you can adjust chairside, but I don't think there's any restorative dentists that are excited about spending an hour trying to adjust interproximal contacts. Also, if we don't have good skills to take a good impression, that also leads to these same challenges and where people may opt to doing individual crowns. Hygiene, I think, is irrelevant almost with these issues. Individual crowns, of course, allows simple flossing. Splinted crowns allows flossing with a threader. I don't think there's a big challenge hygienically with these issues. Load support may be an issue that drives you towards splinting. Of course, sharing the load across the implants, as long as that bridge fits passively, we should have the ability to protect a weaker implant or maybe just make a group of implants much stronger by splinting them together. Individual crowns requires each implant to totally support the load on it independently. And on some situations, it's like Murphy's Law. The weakest implant will have the heaviest load. So you have to make decisions in that regard. I find that most important in the posterior maxilla, but sometimes with situations where I have guidance and other issues on the implants, sharing the load has advantages. I think the first thought, almost on a common sense, is that individual crowns should always be more aesthetic. The surprising thing is, without perfect implant placement, perfect soft tissue reconstruction, many times my ability to splint crowns together, to carry porcelain interproximally, to not have to worry about the line of draw of a custom abutment, gives me more flexibility to create the final result that I'm looking to have. Also, from the point of view of not having one implant per tooth in the aesthetic zone, having pontics also gives me more flexibility to create the aesthetic result that I'm trying to achieve. A final thing is the ease of seating the final bridge, and the first assumption is always, well, cementing crowns, I do that every day, that's got to be easier. But if we don't have cement margins right at the tissue level, and we're trying to cement subgingivally, if we have pontics that put heavy pressure on the soft tissue pontic areas, believe it or not, seating a screw retained crown might be easier than doing cemented crowns. But saying that, of course, it is so simple when we plan these cases well to just take a crown, maybe have an all ceramic custom abutment, and to take that ceramic crown and cement it in place with beautiful margins, beautiful soft tissue contour. Of course, that's a very simple and easy way for us to proceed. The next group of things that we really need to talk about, and I've alluded to already, is screw retained or cemented restorations. Screw retained is always a surprise to me at how difficult for the laboratory it can be to make something that fits my impression, my master model. It's also surprising to me how difficult it is for some people to create that accurate master model. If we can do that, though, the screw retained restoration becomes an option that is very viable and reasonable for anybody that goes to make an implant restoration. The thought with cemented crowns is that basically it's the same techniques as conventional crown and bridge, and which is a good technique. It's simple and straightforward, but I'd like to say that sometimes there are easier ways to do it. I think a cemented crown works better in the flow with immediate restorations, and that's related to the fact that the implants quite often have a slight labial inclination that precludes a direct screw retained restoration. So I expect on an immediate restoration that we're going to do some sort of cemented crown, and that's just what follows. But cementation requires, if we go on a standard crown and bridge technique, it requires a certain axial wall length, requires an understanding that the cement line can't be significantly subgingival, and that we need to think about the contour of that crown as it comes through the soft tissue. So biologically, if we have our crown margins significantly subgingival and we're unable to completely remove the cement that's accumulated there, we expect that not immediately probably, but over the course of that restoration's lifespan, we will have an experience where we'll have an adverse periodontal reaction to the cement that we leave behind. Now also we could look at a a screw retained restoration, and we realize that if we're doing let's say a UCLA abutment, which is a cast gold alloy crown, we bake porcelain on that, but still we have a gold implant interface, the gold abutment, the titanium implant. Will that lead to biologic issues? Abramson made an argument that that's true. Some people will debate that now, but it's something that we need to consider. Is that an issue? Future access or maintenance, my goal with every restoration I do is to never have to remove it. So certainly I'd never use the term retrievability. I mean, I don't like to have to say, well, to clean this restoration I have to retrieve it every few months. That's not our goal. But there are times that there is an advantage to be able to take a restoration out, to alter it, to repair broken porcelain, maybe to add more teeth to it by adding more implants. There are those advantages. If you have a roundhouse cemented bridge, which I certainly don't advocate, if you have a problem in one area, break the porcelain in a significant area, to have to remove that entire restoration is not a goal that anybody would have if you have to go in and cut it off. So that's not our goal. Aesthetics with a cemented all-ceramic crown on a ceramic abutment can be the most outstanding natural aesthetics that we can achieve. It is beautiful, it has beautiful light transference through the restoration, and it's something that I think we all strive to achieve. It is more difficult if you have a metal abutment that may require or show a soft tissue glow of the titanium or gold abutment through the tissue that may not be aesthetic. We also might see that a porcelain fused to metal crown doesn't have the aesthetic potential of an all-ceramic crown. It's perhaps limited by the talent and the care that the laboratory technician puts into the case. So those are balancing, and I think everybody needs to look at their own laboratory support to decide what is the best way to achieve the aesthetic result we desire. The ease of seating the final restoration varies, of course. If you have a simple cemented crown that's right at the tissue level, it can be one of the easiest things we do. On the other hand, though, as I've said again and again, if we have cement margins that are significantly subgingival, this not only is difficult sometimes, but also is very unpredictable in what the final outcome might be that day or months later in terms of tissue response. If we know how to take a good impression, achieve an accurate master model, we have excellent laboratory support, we can seat a screw-retained crown very predictably, very simply. We can carry porcelain perhaps further subgingivally on a given case with a screw-retained. None of these statements are definite. They all vary according to the case that we're working on, and we need to look at all those factors before we make a decision how we'll restore any given case. So my only goal with these two charts was to bring up concepts and ideas that will help you evaluate any given restorative technique. In terms of occlusal anatomy, what are we trying to achieve? I think that it's always reasonable and prudent to attempt to achieve loading of the implant down the long axis. One of the most detrimental cantilevers, especially on a single tooth restoration, on a single molar, is to have a significant labial cantilever. Quite often, practically, the implant is placed more lingually than would be ideal, and then to achieve a full contour to that restoration, we end up with a significant labial cantilever. What we need to do is to perhaps limit or narrow the buccolingual dimensions of our restoration to the point that we keep the occlusal contact closer to the implant position. We also like, in general terms, to flatten the cusp angles for our posterior occlusion. We would like to have centric-only contacts. It's my goal to minimize guidance or transverse loading whenever possible, unless, of course, the more difficult case, our guidance needs to be on these restorations, and then we have to plan them at another level. We can lingualize or buccalize our occlusion based on where the implant's been placed so that we keep the loading directly over the head of the implant. Another issue that I like to look at during treatment planning, and then certainly when we make our restoration, is how can we maximize the hygiene access for the patient, minimize difficulty for cleaning. It isn't always related, and certainly it's just having the ability to floss through separate crowns, to me, isn't some enormous advantage to the patient. It may be as simple as just having the laboratory technician have a proxy brush on hand to create the hygienic space to slip a proxy brush through. It might be considering where the implants will be placed so that we minimize cantilevers or ridge lap situations. Our goal is certainly to have smooth flowing emergence profiles. Now, when we talk about abutments, I like to put them in a couple of basic categories. We could talk about cementable final restorations or screw-retained final restorations. We could also talk about custom abutments versus pre-machined abutments. We'll look at them in both those fashions, but since for the restorative dentist, I think the simplest way to look at these things is how do we connect our final restoration, or how do we achieve that final restoration. I like to split them in the categories of cementable final restorations versus screw-retained. The first category, that's especially for the beginning implant restorative dentist, is an easy abutment, a snappy abutment, a solid abutment that has a very simple impression technique and allows cementing the final restoration. The downside to this abutment might be that it has a fixed cement line at one level completely around the abutment, and in some areas it might be the perfect depth subgingivally. Other areas it may be significantly subgingival, and so we need to look at those. The next custom type abutment for a cementable final restoration is a preppable titanium or ceramic abutment that comes in certain diameters, certain heights, certain angles that allows us to prep, usually in the laboratory, to achieve the correct marginal position, the correct angulation, the correct occlusal clearance, so that we can cement a final restoration. My preference to that type of abutment these days is a CAD/CAM produced abutment of the Procera type, where we can plan the ideal abutment, the perfect angle, the perfect occlusal height, the perfect marginal position, so that we can have this ideal restoration, and we can do that in both titanium and ceramic. Historically, and still today, there are times for me using a UCLA type custom abutment that allows me to create any shape that I'd like to have, and then cement a restoration over the top of it is still a valid way to proceed. I think this depends completely on the laboratory that you have to work with, whether you send your cases to a Procera certified lab or to one that is unable to do that, which in today's world seems unlikely. For screw-retained restorations, probably the standards are either a UCLA abutment, which I'll explain more if you're not aware of that type of abutment, that allows casting a restoration that will be screwed directly to the head of the implant. That is a very valid way to proceed. Also, the use of the multi-unit abutment that has the classical tier of an implant, the multi-unit abutment, and then a gold cylinder. And the gold cylinder is cast into the final restoration. So we have a three-tiered restoration with a gold screw holding the restoration to the multi-unit abutment. So the solid abutment, the snappy abutment, originally the easy abutment, has a very simple protocol of a simple impression coping that snaps over the head of the abutment. Once it's in place in the mouth, we inject impression material, we use a closed tray technique, we pick up the impression coping, send it to the lab with an analog, and in a short period of time we have a traditional cementable crown that looks just like any crown that would be cemented on a prep tooth intraorally. We can cement that crown. Advantages also include the fact that we don't need to do retraction cord, but I would suggest that if you need to use significant retraction cord because the margins are so far subgingival, this isn't an ideal restoration because you shouldn't be cementing that far subgingivally. We can do immediate temporization with these abutments since they come already set with the margins, and hopefully occlusally, especially with the snappy abutment, we don't have to do any preparation at all. It's ready to go. There we go. It works wonderfully, I believe, in a premolar area, in a molar area, where sometimes the aesthetic demands, or at least the soft tissue anatomy is fairly flat, and allows us to cement a restoration with great predictability. Here we just see an example of the impression coat being snapped over the abutment. We would inject impression material around that, pick it up, and send it to the lab. My favorite abutment to use at this point certainly is the Procera abutment whenever I'm going to cement a crown. I have great flexibility in achieving this ideal restoration. I need my laboratory to support me on this in the sense that I need the margins to follow the soft tissue, otherwise I lose some of the advantage of this totally customizable restoration. I like many times to use a ceramic abutment anteriorly. As I proceed into higher stress areas, I still opt more towards using a titanium type custom abutment of this type. We can make these abutments for hex-headed restorations, hex-headed implants, and also internal connection replace type. Procera can be expanded more than just single units. It can be utilized for bridges. For a classic hybrid type restoration, the fixed bone type restoration, we can use it for the core, for the acrylic resin. We can do a more traditional type acrylic metal framework where we have a metal finish line. We can use porcelain that can be baked to this titanium framework, or go as far as the Procera implant bridge with individual all ceramic crowns that are cemented over this framework that has either pink porcelain or more commonly a pink acrylic connected to it, so you have a very natural and aesthetic outcome. All right, now as we look at custom abutments, we'll begin with the historical one, the custom abutment that we developed at UCLA, the custom UCLA abutment. This abutment certainly has been called many different things, the gold adapt, gold cylinder to fixture, but the bottom line is that what we're looking at is connecting the restoration directly to the implant. There are no cement lines, there's no secondary restoration to the abutment. So the abutment, historically the gold cylinder and the restoration all became one, and this was a big issue 20 years ago, 15 years ago when we developed this. Because what it does is it allows us to carry porcelain significantly subgingivally for the first time, and that was a great advantage aesthetically. So our uses still include aesthetics. It includes limited interocclusal space, and I think I can make this accurate statement that there is no way to restore a restoration closer to the implant head than with a UCLA type abutment that becomes the restoration. We also use it for angulation correction as any custom abutment can do. We can vary the angulation of the UCLA abutment and then put a secondary or a cemented restoration over the top. We use it also to make custom substructures, and that's probably my primary use today. We'll make either individual units for custom substructures or splinted custom substructures so that we can achieve the restoration we're trying to have. It's important to understand that there's two basic types of UCLA abutments. One is engaging, so that inside the castable abutment there are components that will engage the head of the implant to prevent rotation. This is what we need to do single units, to do a single custom substructure. But if we're doing bridges, there really is no advantage to engaging these structures inside the implants, and in fact it can lead to problems with the line of draw or other issues. And so we prefer a non-engaging inferior portion to the abutment. From this picture, we can see that there's a precast usual component to the UCLA abutment. It's precast out of a gold alloy, and then there's a waxing sleeve above, so we'll wax directly around this and cast directly to this precast component. We do that to maintain predictability of the fit. There is variability in casting, and we need machine tolerances that may not be possible in any given laboratory. The minimal inner arch clearance, the advantage of the UCLA abutment, is that from the head of the implant we can have a restoration only 3.5 millimeters tall. There is no way to do a cemented restoration at that level, or really any other abutment. Just to look at a case, or kind of a diagrammatic view of a case, we would take the pre-made UCLA abutment, wax directly around it, and we can just barely see in this example the gold UCLA core still sitting there, casting to it. We could take this as the shape of a custom abutment with cemented finish lines, or we could bake porcelain directly to that abutment if we could have a lingual screw access. My goal is not to have the surgeon place the implants to achieve this access, though, because quite often, as you can see in this picture, it leads to the implant head slightly angled palatally or lingually, and then having a non-ideal contour to the final restoration. We can also take that gold casting, place it intraorally, and make a final restoration that is cemented directly over the top. And since the implant was angled more accurately, really through the incisal edge or through the incisal third labially, we're able to achieve a better contour to the final restoration. But if you look closely at the picture, you will see that our cement lines are diagrammed directly at or even to the soft tissue, maybe labially 0.5 millimeter or so subgingivally. In order to feel predictable as a restorative dentist in this regard, we need to feel that the soft tissue is stable. So when we get into the sessions in regards to anterior restorations, we need to talk about the time frames required to achieve that soft tissue stability before we make our final restoration. So we'll look at one other case just real quickly. We see a case with the head of the implant. We've decided to use a UCLA abutment. We do a full contour wax casting, cast it, bake our porcelain, and really it's a screw retained crown. It's simple. What are the debates that we might have this in today's world? We might say, well, that we have an implant to alloy connection here at this level. It's actually sub-bony in some aspects. Will that lead to a biologic width issue? Will it lead to bone loss because of that? And I have to tell you that I feel the jury is still out on those issues. I can show you literally hundreds of cases where we don't have that issue, but I think we need to understand biologically what is going on in those areas. And certainly I could make an argument where there's an advantage to having a all-ceramic restoration, especially abutment, screwed directly to the implant, and then an all-ceramic restoration cemented over the top, as perhaps having biologically more potential. My only issue there is the level of the cement line. Here we're going to just show using a UCLA abutment to create a custom substructure. Just taking the master model and connecting a UCLA abutment pattern to that model, we realize that the screw access hole is going to come out quite a bit labially, and we see this here in this picture. This is not ideal implant placement, but it's the reality of some situations. When we see this, we can go ahead and cut the wax up back to make this ideal shape to the final UCLA abutment, where we could put a crown over the top. That crown could be cemented, or as you'll see here, just to give you another option, we could have a lingual set screw. So we've created our abutment with the lingual set screw. We go ahead and wax the final crown over the top, and then bake our porcelain, and we're ready with our lingual set screw to place the restoration intraorally. First the abutment is placed, and I should point out on this picture, we see a little bit of enhanced redness in that area, and for me as a restorative dentist, I would be concerned about the amount of bone that's in this area with that labial implant placement with labial inclination. But the final result can be very reasonable. It could be screw retained, or from a lingual set screw, or cemented based on your long-term comfort zone with this case. The multi-unit abutment is a progression from some of the aesthetic cone abutments, the conical abutments we used years ago. The advantages being that it's a lower profile. You only need about 4.5 millimeters, so very close to the UCLA abutment, but still a millimeter more in terms of final restoration. The restoration can draw over the top of the abutment up to 40 degrees. So if we have two implants with a 40-degree malpositioning or intentional positioning that's 40 degrees off, the restoration will still draw. There is no hex or engaging component beneath the multi-unit abutment, so it's only used for bridges, and that's a key component. The abutment screw is strengthened. There's angled versions that are very useful. There certainly are advantages for these abutments for those that favor titanium to implant interfaces. Reduces the degree of subgingival work required by the restorative dentist. It may be simpler for them to learn a technique that doesn't require removing healing abutments all the way to the head of the implant. And for those reasons, we do find that some restorative dentists prefer these abutments. Now, custom abutment substructures could be a CAD-CAM type, Procera abutment, titanium or ceramic. It could be a UCLA abutment, a cast abutment. And what these things do, it allows us to create separate units or linked units that then the final restoration will go over the top. They could be held in place with a lingual or a palatal screw. It could be held in place with cement. It just depends on the situation. The indications for these are misaligned implant fixtures, elimination of a screw access hole through an aesthetic zone or the occlusal surface, control of the thickness of the metal and the porcelain in an anterior restoration, so it gives greater flexibility to the restorative dentist in the laboratory, and it develops the proper emergence profiles, which also can be very useful and advantage. On this case, we've used a lingual set screw, but as I've said, easily this case could be cemented. There's no need for a lingual set screw unless you feel that there might be a future of value in easier retrievability than having to cut the restoration off. Each abutment on a separate abutment substructure is that it's designed to engage the head of the implant so it's non-rotational. So we can't use a non-engaging abutment to do this. So an engaging UCLA abutment, an engaging Procera, an engaging preppable abutment would also all be useful ways of managing this situation. Here, a linked substructure gives other advantages. One advantage is that since we know the fit of the restoration to the linked substructure, it always fits intraorally. The biggest challenge with separate single units is if your impression is slightly off, your master model isn't accurate as it needs to be. When you go to seat your final restoration, it doesn't fit the way you expect it to. With a linked substructure, the fit of the final restoration is always exactly the same intraorally as it is in the laboratory. And that's a great advantage. The only limitation might be a pontic that presses on soft tissue, and if you have trouble intraorally in seating it all the way because of that pressure, you may have difficulty getting the restoration seated. But you should know that and then take appropriate steps to get that pontic area seated. So I like the linked substructures because I know if that linked substructure is fitting accurately against the implants, I'm sharing the load more predictably. I don't have to wonder if I have an accurate fit of the restoration. When we have a linked substructure, there's less chance of loosening of the abutment screws that admittedly, as we've improved our implants, has become less of an issue. Here's just an example of a case where we see screw-retained restorations on the patient left, but a linked substructure on the patient right, where with a full contour wax-up, we realize we really need to create this linked substructure to change some angulation issues, and then we can make the final restoration really ideal in terms of the buccolingual dimension, the emergence profile, and the other issues. The value of the linked substructure instead of separate crowns is that it will share the load more predictably. We can also hopefully plan for and execute ideal hygienic spaces to allow the patient to clean these things more easily. Just because we have a linked substructure, that's not a license to go ahead and totally impinge on hygiene space or to eliminate the patient's ability to clean these cases. Now, as I look at restorative implant dentistry, for me, the keys are, number one, that the surgeon and I work well together, that the surgeon understands my limitations restoratively, they help communicate to the patient what those limitations might be, and then executes this near ideal implant placement, or hopefully the ideal implant placement that allows me to achieve the result I want to have. So number one is certainly this surgical biologic understanding of where the implant needs to be. The next key for the restorative dentist is making an accurate model. I think one of the biggest mistakes that's occurred in implant dentistry over the last few years is an attempt to, what I call, dumb down implant dentistry to the point that it's so simple anybody can do it without thinking. Well, the problem with that is that we end up with inaccurate impressions that potentiates itself in inaccurate master models. We make frameworks and even individual crowns that don't fit the same on the model as in the mouth. As restorative dentists, we have that uncomfortable feeling of trying to make something fit or work. We adjust restorations for hours, trying to get them seated. It is an uncomfortable situation, and we start to dread it. I can tell you quite honestly that once I realized how important the master model was to the whole restorative experience, once I had the skills to achieve an accurate master model, implant dentistry was the thing we looked forward to. When we see on our schedules that, oh, good, great, we got 3 implant cases coming in today, we're much more relaxed and relieved than we are if we've got to prep teeth. And that is a great transition, and that's what we should all look for. So we need to examine impression techniques, and we're going to start at the beginning, and then I'll give you the skills so that you can take anywhere from 2 to 8 to 10 to 12 implants in one arch and have the predictability that any restoration that fits that master model will fit predictably in the mouth. So for me, the ability to make a predictable, accurate final impression is the key to making implant dentistry easy, predictable, and successful. There's no reason to make it hard, but sometimes making it too simple makes it much harder, and that's not our goal. The first terminology, and really understanding implants, is also the ability to learn a new language, of the components that we need to utilize. And there are different terms that are thrown about. One is an analog, one is a replica. Whatever it is, whatever we're taking the impression of intraorally, we need an analog of that component, a replica of that component, so we can achieve our master model. It might be at the abutment level, it might be at the implant level. Abutment analogs, we need, for whatever type of abutment we're using, a multi-unit abutment, a easy abutment, a snappy abutment, we need the exact intraoral abutment analog or replica to match with that. For the fixture analog, fixture meaning the implant, for the implant analog, we need the same thing. We need an analog that matches the head of the implant. It needs the same functionality, the same retentive components or engaging components, whether it's a hex or an internal tri-channel, whatever it might be, we need those replicated in the analog. When we have those things, we can generate a very accurate model that will predictably allow us to achieve that restoration, that will fit the same on the model as it does in the mouth. Now, we need to think about ways that we can transfer the relationship of the implant intraorally or the abutment intraorally into our model. To do that, we use impression copings, is probably the standard term. We can take impressions with these copings at the abutment level. If we choose to use a multi-unit abutment or a snappy abutment, we place them intraorally. We then need to take an impression at the abutment level. Many times, though, just to get a little bit ahead of myself, my preference is to take an implant level impression. I don't like to look at a patient and guess what kind of abutment would best serve that patient. Sometimes it is straightforward, but many times on our challenging aesthetic cases, it's very difficult to predict exactly what abutment would be ideal. So when we take the impression at the implant or fixture level, we're able to, in the laboratory, examine all the options to get input from various expert sources so that we can achieve the best restoration for the patient. The other thing, and it's really not another category, but a way to achieve the highest level of impression accuracy is to use what we call linked impression copings. Linked impression copings give us the predictability and the accuracy required to have a master model that will allow us to create the restoration we're striving to create. So impression copings, let's begin at the abutment level, can be open or closed tray. The open tray copings require an opening in the tray, so some part of the impression coping will stick through the tray, allowing us to access that after the impression is set, unscrewing that, and so we can remove the impression. The other type of impression coping is the closed tray impression coping. This allows us to screw an impression coping directly to the head of the implant, and then we use a closed tray or a stock tray, take an impression, snap the impression out of the mouth, and then transfer the closed tray impression coping into the impression. So two basic different types, and we need a different type of impression coping for every different type of abutment that we run into. So just as I've been talking, you can start to pick out the meaning with these terms that we use to refer to these types of impression coping. A closed tray impression coping means that there's no aspect of that coping that requires loosening while the tray is in place. Basically, we screw on the coping, take an impression, pop the impression out, and then access the coping. So a closed tray. A closed tray coping requires transferring. After the impression is made, we must unscrew it from the mouth and transfer it into the impression. The shape of the coping needs to be non-retentive, tapered, so that we can pop the impression over the top of it without tearing or breaking the impression. So those are the classic terminologies used to describe this type of impression coping. Closed tray, we transfer the coping. It's usually of a tapered shape. Here's an example of a case, kind of a classic case. I'm choosing a case with abutments that are actually super gingival, just so you could see everything more clearly. The patients come in, the abutments are in place, we remove healing caps, we connect these closed tray impression copings. After they're connected, we can use any elastomeric impression material. On this case, just for kind of a diagnostic model, we're using alginate. The alginate needs to be well adapted around the copings. We snap the alginate out of the mouth. We carefully unscrew each of the closed tray impression copings and connect it to an analog for that individual abutment. Once it's connected, the analog serves as a handle to slowly snap each of those impression copings into place, and then we can pour a model that's admittedly not perfectly accurate. There's a lot of places where error can occur, especially using alginate, but it gives us a model that's probably more accurate than you expect. Now, the second type of impression coping requires an opening in the tray so that this retaining screw to the coping will extend above it or allow access to the coping after the impression is set. So this is what we refer to as an open tray impression coping. The coping becomes locked into the impression, so it's picked up. The only way it can be picked up with this type of coping is to remove the screw or loosen the screw. Once the screw is loosened, it can be picked up. It never leaves the impression. Its shape must be square or retentive in some way so it gets locked into the impression. So I even like to think of them as locking impression copings because it becomes locked into the impression. So again, from a descriptive point of view, we require an open tray. They need to be picked up, and their shape needs to be locking or squared so that it will lock into the impression. Here's an example of that sort of impression where we will take the squared or open tray impression copings, connect them to our abutments intraorally. They're held in place with a separate guide pin. We seat our custom tray or even a plastic stock tray that has holes cut into it over the top, and we all have that moment of anxiety where we make sure that we can find each of the retaining screws to make sure that we can actually remove the impression afterwards. After the impression is set, we carefully loosen all the retaining screws. We lift our impression out of the mouth, and we can see the inferior border of the impression coping that has become picked up into our impression or locked into the impression, and then we can connect analogs and eventually pour an accurate model. But the question remains with these, how accurate is it? All right, not to confuse the issue, but an important distinction to make is that there is one type of coping that is essentially a closed tray coping, but it behaves as a pickup coping. And that's the coping that we use for our easy abutment, our snappy abutment, where we can snap a plastic coping in place over the top of the abutment, inject impression material, use a closed tray, and then pick it up. So to run through this impression coping utilization, we see the abutment in place, we can snap on the coping, and we make sure that it is fully seated on the abutment without regard to how far subgingivally it is, but ideally it should only be a millimeter at most subgingival. We then inject impression material. Once the tray, the closed tray is seated, once it's set, we can pop the impression out of the mouth, and we notice that we've picked up the margin of the abutment into that restoration. We can then take an analog, snap it into our impression, and pour an accurate final model. So this is the only example of a closed tray pickup coping, so not to confuse things. Now, the next level that I'd like to talk about is the fixture level or the implant level. To me, this is one thing that every restorative dentist needs to master. To be able to use a CAD/CAM type restoration, to be able to make a custom restoration, this is the way to proceed. If you have an idea that you can put abutments in the mouth and then prep them in the mouth, you're really missing the point and making implant dentistry so much more difficult and maybe not achieving the best possible result. The key here is that we're making the impression directly to the fixture. There is no abutment in place, and that's the only thing we need to know. I prefer, whenever we're connecting, especially an impression coping subgingivally, that we take an x-ray. Many people say that, with some of these new implants or the newer types of implants, there's no need for that, but I can guarantee to you, sooner or later, there'll be an issue that the impression coping isn't fully seated, so I think there's value there. The coping, as we've discussed, the same terminology applies, can be open or closed tray. This impression will achieve a implant level model that will allow us to use a CAD/CAM type restoration, a UCLA abutment type restoration, whatever custom abutment or custom substructure we're hoping to achieve. So first let's look at a fixture level closed tray. And the first thing you might notice is that there is a two-piece impression coping, even though it's a closed tray. Once it's assembled, it looks very much like the tapered impression coping. There's no locking components to the coping. We realize we need the two pieces because ideally we should engage the components on the head of the implant that are non-rotational. So a hex-headed implant, we need to engage the hex. A replace implant, we need to engage the tri-channel. The only way we can do that is to have a two-piece abutment. So the shape allows it to stay in the mouth. We can use a closed tray. We can snap the impression out. But we need to have a two-piece impression coping to do that, to allow registration. We can also use some components, impression copings that don't engage the head of the implant, but these are limited in its use and will only allow us to do bridges, and from a laboratory point of view, sometimes gives us problems. So we rarely will use that sort of abutment. Kind of a flow here. We have a fixture level impression coping seated. We notice that there's a screw coming out of that coping, so we realize it's an open tray. When we seat our tray, we will have an impression coping that needs to have access to this screw to remove it from the mouth. Once it's removed, we can add our analog and we can pour an accurate master model. Here's another example of a case. Quite often we begin with a healing abutment in place. We remove the healing abutment and connect our fixture level open tray impression coping. Take an x-ray to verify its seat. Once it's set as an impression, we undo the screw, we lift it out of the mouth, and we notice that we've picked up the impression coping into our impression. And then we can proceed to add the analog and hopefully pour an accurate master model. Now, and that's really, hopefully, is the key term there. Especially for one implant, literally a closed technique, an open technique will give you a very reasonable and very workable master model. But as we progress to anything more than one, questions exist on how accurate that relationship is. We could use every skill that we have. We could seat transfer impression copings or closed tray impression copings. We can have the laboratory splint them together extraorally in the impression to keep any expansion of the impression material from moving them or vibration causing them to shift. We can achieve a master model, but I'm going to tell you that probably the most accurate technique will only give you maybe a 75% accuracy that would allow you to have the exact representation of what we have intraorally, and that's probably being generous. So there's an unknown. Yeah, you say 3/4 of the time, that's a great model, but when is it great? Now it requires a certain amount of unpredictability so that when the restorative dentist goes to the mouth, they have to ask, will my crowns fit? Even if I have interproximal contacts, will they be heavy or open? I have unknown. I don't like unknown. If I'm doing a bridge, will I have to solder? Will I have to separate that unit? And that's a great, sometimes difficulty in terms of evaluating that. How do we know that the master model is accurate? You might say, well, let's use closed tray. That should be more accurate. Yes, it should be, but there's still literally hundreds of points where we can have error. And so closed tray and open tray both sometimes end up with about the same error rates. You could make an argument that an open tray is slightly more accurate, but still there's the unknown and the lack of predictability. For many years, we used to teach the need to do soldering, to go into the mouth with separate units, link them together, and then solder them. Soldering is not a perfect science, and there's certainly error that comes from soldering. It also adds a great deal of chair time and more unpredictability. So my goal is not to solder and wonder if I can make it fit. Let's make an accurate master model. How should we do it? And that's the key. We can go back to the original Brannemark lectures that talked about using a mass of Duralay to link the copings together. Our only issue with that is really maybe the material. Do we have a more accurate material? And using a mass of acrylic all at once has a certain amount of shrinkage, and linking them together in that way is probably not ideal. So could we come up with some techniques? Maybe a technique first that's more efficient from a chairside point of view, so that we can link the copings together with the minimum amount of chairside with the most accurate type of restoration finally outcoming. So let's look at this fairly simple flow here. I call this linked copings technique 1, linked copings 1. Again, I'm choosing a case that is supergingival abutments, just so that you can see everything that's occurring very easily. But the same technique could be done at the implant level, and that's quite honestly where I'm usually doing this. Here we see, very simply, we've added on some closed tray impression copings. You can realize that just from the shape of them. There is no separate component that would allow them to be unscrewed after you seat the impression tray. We seat an impression. This happens to be an alginate, something just quick and easy. We can then remove the impression copings from the mouth, transfer them into the impression by connecting them first to an analog, and then we can generate a model. If you look at this, basically we've invested maybe 5 minutes, maybe 10 minutes of chairside time. So this is a quick and easy. It gives us a good model, especially if we're doing an edentulous case. We have the landmarks we need, the retromolar pads. We have lingual and buccal extension. We have the ability to create an accurate custom tray, and we have a reasonable idea where all the implants are. This model will allow us to create an accurate custom tray. We'll remove the transfer copings from that model. We will connect the open tray copings. We'll go ahead and link them together on this model. And I often use just triad material, link them together very quickly. And then the key here with this technique is that you section them apart, so when you go to the mouth, there's a very small junction between each one of these customized open tray impression copings. I like to number them so that when I carry them to the mouth, I know where each one of them goes. We go to the mouth, and the key here is that as we tighten them, there should be a space between each of the copings, because if they're touching, we realize that there is no confidence that they're seated completely. After they're seated, there's a space between each one. Hopefully the space is very small, essentially the thickness of a business card. We then loop them together or link them together. Quite often today my medium of choice is GC pattern resin. You could use flowable light-cured composite. You could use a cyanoacrylate material, whatever works best in your office. Now I'm going to show you an adjacent technique to this if you have doubts about your laboratory's ability to generate an accurate model. What you might do is take these linked copings, we'll take them out of the mouth, and we'll pour a registration of this index so that we can later evaluate our master model to make sure that there wasn't some sort of laboratory error that led to an inaccurate master model. So chairside will disconnect these linked copings, but since they're just held in place by these guide pins, we can undo the pins, remove it from the mouth, connect them to an analog that matches that case, run into the lab, and we can pour this registration, and I like to use intraoral plaster. I'm not using it intraorally, I'm just using it in the laboratory because it sets in basically about 5 minutes. So it's intraoral plaster type 2, not laboratory quick set that takes about 30 minutes, but intraoral plaster type 2. We now have this registration of my exact position of the implants, so later I can evaluate my master model. I'll tell you honestly that I don't do this component anymore because I have such confidence in my laboratory, but it's up to you to evaluate that. We then place this linked coping back in the mouth. While the registration is setting, I'm quite honestly border molding my tray. I'm ready to take the impression. I fill it with impression material, seat it. One other little technique thing is make sure that that coping is dry. Blow air on it so that when you put your impression material on it, you have a good tight interface between the impression material and the coping. After the material is set, you need to loosen each of the screws. You lift the impression out of the mouth, you turn it over, and you can actually see the underside of each coping, and you evaluate to be sure no impression material was between the coping and the abutment or the implant. If there is, that implies that that coping wasn't fully seated, and you really should reject this impression. We then can go ahead and take analogs. Now it is important that the laboratory use good analogs, that you evaluate the analogs, that you've already evaluated your impression material, your impression copings to be sure that they're not damaged, so that you can connect these components together accurately without any problems. Once they're connected carefully, we can go ahead and pour the model. And now I can tell you, in our experience, we've generated a master model that has always given us a final restoration that fit exactly in the mouth the way that it did in the model situation. We can also have a proof, an index of that registration, so that we can evaluate how they developed our master model and make sure that it's accurate. It took a long time to talk about this technique, but if you evaluated chairside time, it was actually quite minimal. There was only a very short amount of chairside time, less than an hour, to generate a full arch model that you're 100% confident will give you an accurate final restoration. Okay, now another variation to that technique, and let's just be honest, there's times we're not perfect. We don't have open tray copings order. We didn't have time to make linked copings. Patient comes in and all we have in the office are closed tray impression copings, and we want to take a final impression. We decided to give it a shot. We placed the closed tray impression copings. We use a good accurate impression material like a polyvinyl siloxane. We take the impression. We've used good impression copings, hopefully maybe even new impression copings. We know they were seated well. We evaluate our impression to make sure we have good connection between the impression material and the impression coping. After we pop it out of the mouth, we make sure no debris gets into all these little impressions of each impression coping. We transfer them carefully into the impression. We use every impression technique for pouring that we have. The laboratory is very meticulous. We get a model that we think there's a chance we could use. But I still feel we shouldn't progress on and make a restoration and hope that it'll fit. So what I suggest that you do is you use the linked coping technique on the model and then carry it to the mouth to check that we are accurate. And so on the model we might use the exact same technique. We'll put the open tray impression copings on the model. We'll make a triad material framework to link them together, separate it, relink them, carry it to the mouth, and carefully evaluate the fit. And the thing I always tell people is that for me, if it fits, I know it almost immediately. If I wonder if it's fitting, if it I have to tighten screws or twist things or play with it, it probably isn't accurate. And so quickly I'll make a decision. I'll go ahead and separate this thing into its components, and I'll go ahead and use the exact same technique and take a master model. But if it fits perfectly, in a very few minutes, I'll know that it's accurate, and I can go ahead and trust that master model. So I think this is a useful sidelight technique if you ever have doubts. Now, my partner, Dr. Parvaspor, came up with a technique I think that's very interesting and I'd like to share with you. Here in this technique, all you need to begin with is an impression of the healing abutments. We need to know where the implants are before we begin. We don't need that first preliminary impression though. Here we're going to make a custom tray that is basically right at tissue level. There's no vertical height to it because we want the impression copings to stick through the impression tray. We'll go to the mouth, we'll remove the healing abutments and connect, in this case, fixture level or implant level impression copings. I would suggest that you always take an x-ray at this level to make sure that they are fully seated. Once you're confident of that, we then take that custom tray and we go over the top of this. Because the implants may be at an angle, it may not draw easily off over the top of these impression copings, and so we need to enlarge the access holes until it will draw easily. We'll also border mold the tray as is necessary. This is the tricky part. When we take our impression, we need to really wipe the impression material off of the impression copings and off of the tray in the area directly surrounding the impression coping. The goal is then to take GC pattern resin and with a liquid powder technique and a small brush to pick up liquid powder, a little bit of GC pattern resin, and make a little dab, maybe in the most mesial portion of the tray. And then we will proceed down to the opposite end of the impression tray, and we will achieve a little dab of GC pattern resin in that way. And so we'll slowly work back and forth across the impression tray until we link the impression copings to each other as well as to the tray. The key here being you don't take a big mass of GC pattern resin and just stick it on all at once, because then we have a significant amount of shrinkage. By the time we're linking them to each other, the material has stabilized and doesn't shrink as much. After it's fully set, the GC pattern resin, and we've linked the copings to the tray, we then carefully remove the screws or loosen the screws, lift the impression out of the mouth, add our analogs, and then the laboratory technique for pouring the model is very critical, so we have an accurate model. And this also achieves an accurate model. Here's another example of the same technique. Here's an example, a unilateral case that did have 6 implants. We made a fairly general opening in a custom tray. Usually I like it a little bit more accurate than this, but we went ahead and made a fairly general opening, made sure we could seat the tray, took an impression, wiped off as much of the impression material as we could, and then linked the copings to the tray. And this was, admittedly, for me, the first time I used the technique. After we take the impression, we put the healing abutments back in place. Our impression we remove, we go to the lab, we connect analogs, and the laboratory will pour this accurate model, usually a soft tissue cast, so that we're not damaging the model just trying to remove the impression copings. For me, on this case, I had doubts. I had doubts about its accuracy. So one technique, as we've already described, is to put the open tray impression copings on this model and link them together. And I used a technique here that I actually use intraorally quite a bit, with the floss running between the different copings, taking just a dab of GC pattern resin at a time, slowly building up this framework of a GC pattern resin, not a big mass of acrylic all at once. Once it's set and fairly rigidly set so that there's no flexure in this framework, I can carry it to the mouth and we'll go ahead and evaluate the fit. And here was a great feeling for me in the realization that this check fits so accurately, both from the terms of I've proven my master model, but also for the technique I used to generate this index to evaluate the fit in the mouth. Now I know I have a lot of different techniques to have an accurate master model, and I can utilize what's best for any given patient. Here's an example of a case with, let's say, multi-unit type abutments. There'll be a gold cylinder and a restoration above that. In your mind, do you feel it's necessary to do anything other than put in closed tray impression copings and take a quick impression? And I would tell you, even if you were choosing a different kind of abutment and doing cemented crowns, separate crowns, I would still put a little bit of effort into the master model because it'll make everything go faster and more predictably as we finish the case. For this sort of case, I would use open tray impression copings right in the mouth, but instead of taking the impression, I'm going to link them together. just right in the mouth. I'll use some GC pattern resin, or in this case, some triad material, and I'll link them together. I take them out of the mouth, I put them in the light oven, I cure it even harder. I then section it, bring it back to the mouth with separate pieces, but the key is a very small section, so I could just paint on some GC pattern resin. I've linked them together. I will usually use a stock plastic tray, cut some holes in it, and I'm able to generate a very accurate model that, regardless of my final restoration, whether it's single units, whether it's a splinted bridge, I will always find the accuracy of fit quite high, and my chair time will be greatly reduced in trying to make the restoration fit. So that's my key there. I will show you, though, the technique I'm probably using most commonly today, and that's just going to the mouth with two open tray impression copings and linking them directly. Like I alluded to earlier, we could use a floss matrix to help support the GC pattern resin, but quite often with two impression copings, just slowly dabbing it, the GC pattern resin really doesn't run. You're able to put a little dab of material on each impression coping and slowly build it up until we have that connection between the two that links them together to give the accurate model. Now, if you look at the very first picture here on the left, and you see the saliva kind of coating the impression material, that's my one concern for you. You always need to make sure that you're working in a dry environment. The copings need to be dry so you have good adhesion of the pattern resin, or even if you're just taking an impression, that the impression material is well adapted to the impression coping. It needs to be dry. You need to maintain that dryness to have any kind of predictability. With this technique, after you've linked them together and the pattern resin has set, you inject impression material all around it. You have a custom tray or a stock tray with holes drilled into it to pick up those impression copings, and now we've achieved an accurate model. I've used this technique up to 8, even 10 implants, as long as the implants are fairly close together. If they're significantly spread apart, like on the all-on-4 technique where we only have 4 implants that might be significantly spread apart, for me it's much easier to have pre-made blocks of acrylic that I just need to place in the mouth and then just fill in a small little gap, and then still use the impression technique. Now, many of you I may not have convinced that you think, oh, shoot, that's easy. Most of the time I don't have a problem. I just use closed tray impression copings and I make a final restoration. But I guarantee you, on a bigger case, all it takes is one restoration that doesn't fit, and you have that moral dilemma of whether or not you should proceed on with the final restoration that really will create a great deal of problems for you and lead to issues in terms of predictability. So I strongly suggest that you find your own technique for achieving predictability of the master model, and when you do that, implant dentistry becomes easy and predictable and will give you the results that you want to have. Thank you very much.